cancers, or we call another case lung carcinomas. That is the primary lung tumor, which is originated from epithelial cells of the lungs. And today, as you can see in the pictures which I shown in your slide, that is the main oncological problem for both genders, and for males and for females. I want to say you that the incidence of this problem is huge. I put, by the way, the newest epidemiological information. I take it from Lancet. And it is shown that in 2022, more than 2,050,000 new cases of the lung cancer is registered along the world. And approximately 53–54% it is the males, approximately all another percents, 47 approximately, that is the females. Let's say, when I studied medical university, our teachers said us that twice more usual that problem is presented for the males than females. Now you can see the situation is changed. Approximately incidence of the males and females come to the same situation. Let's say to be ready that in the future, maybe even for the females, it will be more usual than for males. It is connected with behavioral problems, mainly smoking. With laughter, I will introduce it for you. Now, a little bit about the statistical information. Among all cancers, that is approximately 30–35%. Among all mortalities, it is near the 20%. 20% of all mortalities, it is the lung cancer. I think you don't imagine even what about I speak. This is the huge, awful situation, guys. About age and about gender. As I say you today, by case of the gender, we have equal situation. Age, right please, 6, 7, and 8 decades of the life. Let's say persons after 60 up to the 80. Geographical areas. That is more usual for the European countries and North American countries. Let's say developed countries. By the way, I find in the United States information connected with some race connection. Right, please. For example, United States informed that black race persons, African race persons, have approximately 5% more mortality than whites. They connected it with social level. For example, immunity system, the normal feeding and something else, but that doesn't connect it with genetically. Let's say, remember please, generally lung cancers doesn't have any genetical predisposing. That is exception, by the way. All the mutations which we see here, it is acquired mutations, not inherited mutations. Little after I will show it for you. Now look please here, about very interesting, by the way, here, news slides which is show for your incidence. Look, breast cancers and lung cancers today located in the same level. But mortality of the lung cancers 3 times approximately more than the breast cancer. It is greatly visible here. By the way, for the males, I want to say that it is not most widespread kind of the cancer. Most common is the prostate cancer, as you remember. But the mortality of the lung cancer 3–4 times is more than mortality of the prostate cancer. Remember, it is very important. Till now, I spoke about the epidemiological situation of primary lung cancers, but don't forget that approximately 10% of the cases we have secondary lung cancers. What is it? It is metastasizing from another tumors, another locuses into the lungs. 10% of the cases. And I want to remind for you guys that mainly into the lungs pass the cancers from abdominal cavity. It is upper compartment, liver, spleen, stomach, very usually. And head and neck cancers, for example, thyroid gland, also very widespread. It is go not only to the bones, as I said you yesterday, but also to the lungs. And it is connected with lymphatic spreading, as you remember maybe. So remember body. Right, please, the survival of the problem. Very interesting situation. Look, local cancer of the lung, 5-year survival, it is 50%. Listen what I tell you. Local cancer, cancer in situ, 5-year survival, 50%. Non-local cancer, if it is spreading into the lymphatic nodes, open the brackets and write please, 14% survival. For metastasis, survival less than in 3% of the cases. 3% of the cases, if the lung cancer gives the distant metastasis, 3% survival of the patients. You understand? So awful situation we have today. Let's remember, once again, you know bronchoalveolar, I think you know, yeah, little after I will give you, bronchoalveolar form of the lung cancers, which we call cancer in situ. It is the less dangerous form. Why? Because it doesn't spread it is local. It is sitting inside of the mucous membrane. 50, here even I write 54%. It is United Kingdom information. And primary treatment surgical, after I will show for you. We resect it, we remove it. Even we don't make the chemotherapy, but we make pulmonectomy or lobectomy. Let's say we make wide resection to remove all possible tissues which can be involved inside of this cancer. Now, right, please. Next information, of course, it is etiology, pathogenesis, mixture of everything. I confused day by day, then I see information, guys. Really specialist oncologist. And yesterday I have big argue with our one famous professor. Especially we speak about lung cancers. Guys, it is impossible to have in the same time smoking and like etiological factor and like the risk factor. Now, majority of the books today of oncology say you, smoking, it is etiological factor of formation of the lung cancer. I agree with this. Because primary, they can make formation of the lung cancer because of the two problems. Right, please. Problem number one. It is the cyclic hydrocarbonates, cyclic hydrocarbons, which is located in the smoke. Problem number two. In non-smoke tobacco, we have N-nitroso nor nicotine. Both is cancerogenic. By the way, inside of the smoke, we have 7,000 different chemical substances. But the most important is two. These two make the mutation, and 5 main stages will be happening inside of the lungs to form the lung cancer. Right, please. Because of the influence of these two substances. Problem number one, right, please. Basal cell hyperplasia. Basal cell hyperplasia. That is the first primary stage of formation. Problem number two, stratification. Problem number three, squamous changing of the epithelial cells. Squamous replacement, we call it. Why especially squamous? You can say, but what about adenocarcinoma? Adenocarcinoma, it is not only smoking person tumors. 99% of the smoking persons has the squamous cell carcinoma. Don't forget about it. And finally, last one, not last, fourth one, it is formation of the cancer in the situ. Local cancer. Fourth stage. Now, fifth stage, of course, it is spreading of the cancer into the different tissues. What does it mean? Cancer in the situ, it means it is in the level of the basal membrane. It doesn't spread it to another wall layers, yeah? There's a fifth one, I don't write it here. I write here only 4 stages. But remember, please, stage number 5, then it is spreading to all another layers. Macroscopically after, we will say you which kind of the grades and classifications we have. But generally remember, from hyperplasia we start, and from the spreading of the tumor to the different layers of the lung tissues, we finish. 1 minute now, look to me. What is the problem here? Really, we come to conclusion that the smoking, it is the etiological factor. Can I say that etiological factor can be also the risk factor? That is very hard, friend. For example, influenza virus, even if you have contact that it doesn't make infection of you, it cannot be described as the risk factor. Anyhow, it is the etiological factor. Other problem, will you be infected after contact or no? Same and here. You can smoke and don't have this problem. It doesn't mean that it is become to risk factor from etiological factor. Let's say how logically you will understand. There are two types of the persons. One is smoke and have the cancer. For him, cancer, it is etiological pattern. Second is smoke, but in this time, now, he don't have the cancer. But incidence of formation of his cancer is huge, bigger than for non-smoking persons. From that point of view, smoking we can describe like the risk factor. But in real case, again I say, it is not the risk, it is the etiological factor. Just for the person who didn't have, now in the time of investigation, this problem, we say it is risk factor. And we mentioned that smoking persons, write it please, who have the more than 20 years time of the smoking, and who smoke more than 20 cigarettes during the day, have approximately 5 times more chance to have the squamous cell carcinoma, 5 times more chance, comparable with another persons. For example, United Kingdom literature say another case. They say 20 years smokers has approximately 2-3 times more, but 40 years smokers have more than 5 times. Yeah, but average literature show that if there are 20 years stage of the smoking, and if the person smoke more than 20 cigarettes during the day, approximately up to 5 times more usual. It doesn't mean that, for example, adenocarcinoma for that persons will be same to non-smoking persons. No. Just for adenocarcinoma, guys, you must understand that it can be and for smoking persons and non-smoking. Squamous cell carcinoma, 99.9% of the cases, that is the smoking person problem. Adenocarcinoma, no. Approximately 70% it is smoking, 30% never smoking persons. That's a you must remember about it. That is important. Right, please. Another risk factors. Another. By the way, here I write that the passive smoking, or we call it environmental smoking, it is also increase the chance of formation of this problem. By the way, stopping of the smoking, investigations show that the persons who stop the smoke, chance of formation of the cancer approximately twice less than for actively, but twice more than for non-smoking persons. You understand what I say? If the stage of the smoking person, 20 years, which I say you recall, and this person make that cessation, finish to smoke, he will have twice approximately less chance, comparable with actively smoking 20 years or more, but twice more chance comparable with non-smoking persons. And you know, again, I find very interesting information. For that persons to come approximately to the level of non-smoking persons, from 10 up to 20 years will be passed. Do you understand me? That's like, if you finish to smoke, and touch wood, of course, you live normally next 10 years, your chance to have the lung cancer will be approximately equal to the chance of a non-smoking person to have the same lung cancer. But before that time, your chance to have the lung cancer will be approximately twice more. It is understandable for you. Right, please, another risk factors. All of them approximately, it is external factors. Generally, internal factors here we don't describe. First one, the radon gas. Radon gas, you know, it is the radioactive gas. Usually, for example, we see high concentration in the places with mineral waters. Springs, mineral waters. For example, in Armenia, there are 2-3 places I know with high concentration of the radon. Radon can be used for treatment, by the way. It is a physiotherapeutical treatment also provided by radon, but in high concentrations, it can give formation of mutations. Any radioactive elements, not only radon, can make the mutations, acquired mutations of the cells. That is not inherited mutation. This is acquired mutation. Again, will be the same stages, which I say you, from hyperplasia with formation of cancer in situ and spreading of the cancers to another layers. Next one, any pollutions, radioactive dust, just I don't know, asbestos, Asbestosis is very important professional disease. Yeah, I think you see what is the asbestos. Asbestos has the crystals, which is very sharp, and which is make mechanical irritation of your respiratory system. They perforated the respiratory organ walls, and they cannot be phagocytosed. So they doesn't clean from the body. They make chronic inflammation, chronic irritation of the mucous membrane. What is the result? I say hyperplasia. Hyperplasia 2 minutes before we say about it. Let's remember about genetical factors. Respiratory viruses also can be. Yeah, by the way, this is very interesting. Smoking, it is a risk factor for chronic respiratory diseases, which is pre-cancerogenous situations. For example, any type of bronchitis, any types of emphysemas, yeah. Let's say, from that point of view, really smoking can be described like, don't forget also, that smoking also decreases the immunity system. From that point of view, again, it can be described like risk factor, because low immunity, it is not the etiological cause of formation of the cancer, it is a risk factor. It is the predisposing situation. And finally, about genetical, the RAS, CRAS, TP53, which we described before. But all these kind of the mutations, it is acquired mutations. It is not the genetical. It is not inherited. Very interesting, guys. That is the maybe one exceptional type of the tumor, which today, maybe in the future, we will find really genetical predisposing of formation of it. But today we don't find. And today, majority of the cases of the lung cancer, we simply associate it with external problems, which I described you before. Starting from smoking and finish by some chronic diseases of the lungs. Let's say that is interesting. That is interesting. Let's continue now, right, please. Pathology of the problem and macroscopic classification of the lung tumors. Macroscopically or pathologically, we can say that the lung tumor divided into 3 main types. And the most usual one, it is the peripheral lung tumors. Not the first which I write here, the central or the bronchial, but the peripheral lung tumors. Why it is the most usual one? Because the most usual histological form of the lung tumors, it is adenocarcinomas. And adenocarcinomas, write and remember please, mainly belong to the peripheral type of the tumors. What does it mean? Open the brackets and write please. This is kind of the tumors which is located or inside of the interstitial tissue of the lungs, or inside of the small bronchi, starting from segmental and bronchioles. Don't forget that this is macroscopic classification. It means pathologists cannot find inside of the lumen of the bronchi any volumetric process. You understand what the problem? Because bronchioles cavity cannot be open. It is macroscopically undetectable structures. Idea is understandable for you. So remember, main type of adenocarcinoma is peripheral type of the tumors. Right? Please say the second one. Main bronchial tumors. Open the brackets and write, please. This is the first, second, sometimes third level of the bronchi. Let's say main bronch, lower bronch, sometimes segmental type of the bronch. Endoscopically detected type of the tumor. Let's say inside of the bronchi, as you can see in our picture, this is endoscopy. We see invasive process. Compare it please with the peripheral type of the tumor. You can see that no any connection with the lumen of the main bronchus. Let's say main bronchial type and finally peripheral types. Let's say this is again I say you, that is not histological classification. that is just the macroscopic. Open the brackets and write, please. Majority of squamous cell type of the tumors and large cell type of the tumors. By the way, you know today is the science say that large cell type of the tumor, it is the bad diagnostical type of the tumors. Really, we don't have such kind of the histological tumors, just we cannot identify what is it. So remember, but anyhow, till now we describe this histological group, the large cell type of the tumors. Remember, please, mainly squamous cell and large cell type of the tumors. It is resembled to the first one, the main bronchial tumor. And last one, right, please, we call Pankos type of the tumors. Different pictures I can show. For example, here you can see apical form. Much more better it is visible here. Yeah, you can see, right, please, 60–70%. What does it mean? Right, first of all, Pankos type of the tumor, that is tumor which is spreading in minimum one lobe of the lung. Minimum one lobe of the lung. In majority of cases, 60–67% of the cases, it is superior lobe. It is superior lobe. By the way, very specific sign, the Gorner-Bernard sign. Yeah, you know, same sign we have, then we make the vagosympathetical blockade. Yeah, now in the neck region, as you remember, we have the vagus, we have sympathicus. Then it is enlarged, it is pressed these structural units and gives the Gorner-Bernard. So you can understand that this is the Pankos one. Right, please, in approximately 20–25% of the cases, like you can see in this picture, it is spreading in all lung. One of the most aggressive one, right, please. It is mainly small cell type of the lung cancers. Most aggressive form of the lung cancers, guys. Small cell. A last type, which is not identified macroscopically, but which is need to be described, this is cancer in situ, of course. It means no macroscopical evidence. We don't see macroscopically the tumor because it is located in the just mucous membrane. It forms the microscopical sign. We call it non-transparent glass sign. Because of the hyperplasia, we see non-transparent mucous cells. Yeah, little after in the histological preparation, I will show. That's it. 1 minute, guys. In your state exam, don't say that macroscopically there are 4 forms. No, there are 3 forms. Last form, it is minus macroscopy. We don't have macroscopy. It's like this is the tumor, but macroscopically we cannot classify it. Now, right, please, histological classification of the tumors. According to the size, according to the form of the cells, according to the level of differentiation, according to the level of differentiation, all lung cancers divided into 2 big groups. There is the small cells and non-small cell lung cancers. Open the brackets and write, please, approximately 30% and 70%. 30% of lung cancers, it is small cell cancers. In the diagram, you can see red color. Another 70%, it is all another non-small cell lung cancers. Right, please, non-small cell cancers, mainly divided into several groups. First one, it is adenocarcinomas. Majority of the lung tumors belong to the adenocarcinomas. Right, please, approximately till 40–45% of all cases. We call it cancer of non-smoking persons. Cancer of non-smoking, but I say your evidence to see it for smoking persons is very high. Second one, it is the squamous cell carcinoma. Little after I will show for you histological form, type, just now classification. Vice versa, we call it the smoking person's cancer, yeah? In the brackets, right, please, it is, by the way, not so big percent. It is less than small cell types, approximately 10–15%, not more. Next one, it is cancer in the situ, which we call bronchoalveolar form of the adenocarcinoma, bronchoalveolar. It means it is located inside of the bronch and alveolar, but in the level of the basal membrane. It doesn't spread into the deepest structures. And last one, some literature call it the idiopathic form, yeah? But much more better, much more usually we call large cell types of adenocarcinoma, large cell types. This is the cases which is not identified normally. This is called a large cell. Right, please. First main type, it is adenocarcinoma. Classical tumor from epithelial tissue. From epithelial tissue. Before we speak about a lot of another forms, yeah, of adenocarcinoma, for example, the glandular tumors, yeah, which is also have the form of the adenocarcinoma. Now look in the picture. What do you see? In the mid side of the preparation, you can see small bronchi. Outside of the small bronchi, you can see atypical hyperplasia. It is hard to say which kind of the tumor of it, because they doesn't have the differentiation. You see some big cells with the big nucleus, and which is by many layers. Normally, you know, one layer cells surrounding the wall of the bronchi, but now look how many layers we have. And macroscopically, you can see classical epithelial type of the tumors. No so good vascularized, no any cavities, no any other type of the tissues inside of it. Here also you can see no connective tissue, no stromal elements, nothing more. Generally the cells. It is conglomeration of the epithelial cells. 70%, as I say, it is the peripheral type of the tumors. Usually slow-growing type of the tumors. Slow-growing type of the tumors. And not so highly metastasizing forms. Not so highly metastasizing form. By the way, in the brackets, right, please, it is very important. Mainly hematogenous type of the metastasis, not the lymphogenous. Lymphogenous, it is for small cell and squamous cell. Remember, please, hemostatic form of the. Open the brackets and write, please, the main phases of the metastasis. Little after we will speak much more about it, but write, please, main phases of the metastasis: bones. Number 2, brain. As you remember, then we speak about brain, I tell you that 10 times more usually we see secondary tumors, and main locus of secondary tumors, it is the lungs. Brain, remember, please. Number 3, breast. Very interesting. It can give the spreading into the breast. And again, I tell you, this is not the lymphatical types. Lymphatical, vice versa. From breast is going to deep. This is from deep come to superficial. That's I remember about it, please. Don't mix it. Continue, please. Right, please. Second type, histological type, it is squamous cell carcinomas. Doctors like it. You know why? Because that is exactly type of the tumor which show absolutely connection with the smoking. That's why it proved that really smoking, this is the cause factor for formation of the primary tumors. 99% of the squamous cell cancers associated with the smoking. And especially that is the smokers with 20 and more years stage of the smoking. Remember, please, that is important. You can see a classical picture. It is central bronchial location of the tumor. If the previously we speak about peripheral location, here you can see central bronchial location. And it is very logical, guys. Of course, if the person is small, mainly the walls, the mucous membranes of the bronchial tree will be irritated. Not the interstitial tissue, but the mucous membrane of the bronchial. And you can see what is important, guys. Do you remember previous picture? Solid, big, tumor, epithelium. Now look, necrosis. Caliquotous necrosis, that is very specific for squamous cell tumors. Right, please, formation of the cavities inside of the tumor with necrotization. Size is twice smaller. Usually, remember, please, size of the squamous cell tumor not more than 2, maximum 2.5 centimeters. If adenocarcinoma can withstand up to, I don't know, golf ball, for example, yeah, or tennis ball, here no. Why no, guys? 1 minute attention. It is so aggressively grow type of the tumor that it much more quickly spread it and gives formation of the distant metastasis, and person is die before formation of the big locuses inside of the lungs. You understand? Mortality of this type of the tumor is second after the small cell lung. Let's say this is very aggressive. Open the brackets and write, please. Mainly lymphatical drainage. On this lymphatical drainage, you understand. First locus, it is mediastinum. First locus will be mediastinum. Supraclavicular, infraclavicular lymphatic nodes, mediastinal lymphatic nodes, caval lymphatic nodes. Let's say the nodes which is collected, the ductus thoracicus. Nodes which is collected the lymph from the lungs. Remember about it, please. Let's continue. Right, please. Next type of the tumors, it is the bronchoalveolar tumors. Tumors of lucky persons. This is a really lucky person's tumors. Why? Because that doesn't spread it. We say that bronchoalveolar tumor, it is not aggressively grow type of the tumor. It is seated in the mucous membrane. 10% of the cases, then it's spread by the lymphatics. By the way, previous one I say it is spread lymphatically. 10% of the cases, cancer in situ can become to the non-localizated type of the tumor and gives the metastasis into the lymphatic system. Lymphatically, it doesn't. Why? Because in the mucous membrane, we don't have so good developed vascularization. But we have the good lymphatic structures. So you spread it. What do you see? Of course, no any macroscopical. By the way, I forget to show for you microscopical picture of squamous cell. Look, very interesting. Locus of necros. Surround of the locus of the necros, you can see huge amount of absolutely anaplastical, but type of the cells which has one way is called squamous. You know what is this? Because they sit one into another and they form the squamous layering structure. Look how many layers of the cells we have here. That's what we call it. If you remember, I tell you that after the, for example, influence of the oncofactors, we see the squamous, first of all, the proliferation, and then squamous changing from the normal epithelium into the squamous type of the epithelium. And finally, formation of cancer in situ. Why I show it? Because in case of cancer in situ, you see the same squamous type of many layers. Look how many layers. Like the roof that we close by something, yeah, we put one to each other, yeah, like the squamous. Let's say cancer in situ, histologically, it is very resembled, but what is difference? You see high differentiation of the cells. So you see approximately, they located by many, let's say it is proliferation of the mucous membrane, but high differentiated. Previously, I should show for you proliferation and low differentiation of the cells. That is only difference. Because microscopically, everything is same. But here you identify that it is normal alveolar. See? In previous picture, you don't understand what is it. It is epithelium of skin or it is epithelium of the lung. Nothing specific. You understand it or not? Now, right, please, last, most aggressive word. No, about large cell, I even don't want to speak. Because I think then you will start to work in the clinical practice. This term will be disappeared from medical literature because, as I tell you before, that is non-differentiated, non-identified type of the tumors. Only one specific characteristic looks so big, huge. In your home, if you will look, very big cells, epithelial cells, which is very big, and ratio of cytoplasma and nucleus, it is twice less than for normal. Usually, you know, cytoplasma is big for normal cells, nucleus is small. Here, ratio is changed. Cytoplasma is small, nucleus is big because it is actively growing. And again, you don't see any differentiation. But what is specific? Large cells. This large cell type of the adenocarcinomas, like the squamous cell, usually has the central location. It is not the peripheral type of the tumors. And again, usually it is lymphatically spreading type of the tumors. So remember, please, mainly hematogeneously type of spreading we describe for adenocarcinoma. All another type of the tumors, little after I will show for you small cell tumors. Yeah? This is aggressively passed by the lymphatic system. Now write please, small cell tumors, otherwise we call acute cell tumors. This is the tumors which is originated from hormone productive type of the cells, or carina cells. You know, carina located in the place of bifurcation, yeah? And what is specificity of them? Very small histological form of the cells, no any cytoplasm. You see one big nucleus. Look please here. Cytoplasm is very narrow shadow which is surrounding the nucleus of these cells. Look, approximately absent. It is artifact. It is the coloring, it's just in the midside. Let's say approximately absence of the cytoplasm. Let's say, right please, the most aggressive, the most metastatic, and the most dangerous form of that, lung cancers. Approximately survival of such kind of the patients, it is less than 3–4%. 1 year survival. 1 year survival. Very short, guys. And usually it is shows some endocrinological signs. For example, it's endocushing. Or for example, it is productive antidiuretic hormone. Let's say a little after, then we will speak about sign of symptoms. We will become again to this problem. Let's say if very specific, no any other type of the lung cancer doesn't show endocrinological signs, only acute cell type of the tumors. And right, please, the main form of the metastasis, it is the lymphogenic metastasis. But here there are problems, guys. I write, yeah, that it is mediastinal lymphatic metastasis. But again, information is not so clear. You know what is the problem? Acute cells or endocrine cells has the huge communication with the vessels. You should understand that they produce the hormone inside of the vessels. That's why I find in the literature also information that they can equally spread it and by lymphatical system and by hematogenous system, but mainly by lymphatical system. That's why I write it here and I teach you classically that this is mainly lymphatical type of the spreading. But just histologically, remember please that these kind of the cells, they connected with the vessels. They produced the hormones inside of the vessels. It's of course chance of formation of hematogenous type of the metastasis is very high. Continue please, now write please the main ways of the spreading or main ways of the metastasis of the lung cancers. First one, direct contacting way. In the brackets write please with formation of pancoid type of the tumors. Let's say, then we speak about direct contacting spreading of the tumors. We imagine the pancoid type of the tumors. This is the tumors which is spreading through the whole lung. Open the brackets and write please. In majority of the cases, histologically it is squamous cell type of the tumors. It is the squamous cell type of the tumors. Why it is so, guys? As I said before, this is the low differentiated cells which has very aggressive growth. You can say me, why not small cells? Simply because small cells will be spreaded and gives the far metastasis. Person will not live so long to have the pancoid type of the tumor. Before this, 10 times he will die because of the distal metastasis in brain, for example, or in another organs. So remember about it. Second one, intrabronchial spread. Again, central localization of the tumors. Again, the squamous cell type of the tumors, the main type which is spreading by this way. And what is happening, guys? Total obstruction. total obstruction, formation of the atelectasis, inflammations, because if the bronchial tree is obstructed, you understand that atelectasis will be formed with future pneumonia, inflammation. This is very specific for bronchial type of the spreading. Continue please, the blood spread. Again, I say you adenocarcinoma, the main form of the tumor which is spreaded by the blood. Ways of the spreading, I tell you 2 minutes before, Look it, try to find it in the brain, try to find it in the breast, it can pass to the liver. Let's say this is the main site in the bones, by the way, I forget to tell you, it can be spreaded into the bones. This is also specific for you. And finally, last way, right, please, it is the lymphatical way of the spreading. The lymphatical way of the spreading. You know, 12 groups of lymphatic nodes mainly we describe. And the first one, it is so-called healer, which is located in the hilus. And 20-25% of the cases, metastasis is spread into healer group. By the way, this is the level N2. Especially if it is IPSI. Contralateral opposite side, it can be N3, but it is not N. It is not the distant metastasis, it is the level of N. Remember about it, because usually you think, why we call it metastasis if M is 0? M is 0 because we don't have distal metastasis. But if the lymphatic nodes involve inside of the problem, we call it the lymphatic metastasis. Continue please. Second group, it is the bifurcational group of the lymphatic nodes. Third group, it is sub-bifurcational, or also we call it esophageal group of the lymphatic nodes. And next one, it is the mediastinal group of the lymphatic nodes. Mediastinal group of the lymphatic nodes. Next to it is infra and supraclavicular group of the lymphatic nodes. Infra and supraclavicular group of lymphatic nodes. Next one, it is aortal group of the lymphatic nodes. And finally, ductus thoracicus inferior carotid. That is main group of the lymphatic nodes which can be involved in the spreading of metastasis from the lung cancers. Remember, please, by the way, we have the Japanese classification, which is little bit different, like in for gastric cancers, which is little bit different from TNM system, and which is exactly show the spreading of the tumors through the lymphatic nodes, which I mentioned before. They like to show the lymphatic metastasis. Let's say their classifications according mainly by the lymphatic metastasis. Remember this group of the lymphatic nodes. Now, right, is N1. It is interstitial lymphatic nodes inside of the lung tissue. N2, ipsilateral healer lymphatic nodes. N3, all another. N3, all another. All another, which is more far from the lungs, or which is contralateral in the opposite side, they belong to the N3 stage. Well, let's continue, guys. Now write, please, the signs and symptoms. Signs and symptoms. Firstly, signs and symptoms of the primary tumor. Sign and symptom of the primary tumor. Group 1. Symptoms connected with the respiration. Symptoms connected with respiration. Open the brackets and write, please. They originated due to the chronic inflammation of the mucous membrane of the respiratory tract and obstruction of them. Also, especially need to mention the invasion of the tumors into the vessels and formation of the bleedings. Intra-respiratory bleedings. Hematoptysis, Yes. Let's say, right, please, number 1, cough, usually productive, with the sputum, which can be inflamed, which can contain the blood. Generally, you know, hematoptysis is divided into micro and macro. Micro if it is the blood in the side of the sputum. Macro if there are the bleeding through the respiratory tract. Yeah, if it is profuse bleeding. That's why we can see on the micro type of the hematoptysis and macro type of the hematoptysis. Connected with the stage, connected with the situation of the patient. Right, please. Also, we can see the pneumonias. Because of the atelectasis and inflammation of the lungs, it is also respiratory system signs, yeah, symptoms. Dyspnea, tachypnoea, that is the signs which is connected with the respiratory system. Now, right, please. Group number 2, this is the signs which is connected mainly with intoxicational problems. I don't write it here, but I write this. Intoxicational problems. Open the brackets and write, especially specific for squamous cell type of the tumors. Why? I show for you necrosis. And that is the main type of the tumor, which is give the locuses of the necrotization. No in case of adenocarcinoma. No in case of the small cell type of the tumor. Especially squamous one. Open the brackets and write with fever. Main sign, fever, weakness, dizziness,
anemia,
anemia. Usually, guys, malignant forms of the anemia. That is anemia which is not treated by medicines, by the vitamins. That is the anemia connected with the problems with the bone marrow, yeah, with the formation of the new bone cells, yeah, that is the big problem. Continue, please. Third type of the signs. Again, I don't know why I don't write it. It is the compressional signs. Connected with compression of mediastinal structures. Right, open the brackets and write, please. Inferior caval vein, ductus thoracicus. In the brackets, write, please, swelling of head and neck regions. Because of abnormal drainage of these regions, yeah, the lymph cannot be drained and venous blood cannot be drained to down because inferior caval vein it is pressed. This is, by the way, not so seldom situation. As I said you before, majority of lymphatic metastases pass finally into the mediastinum. And if the inside of mediastinum will be volumetrical processes, of course, the inferior caval vein and ductus thoracicus can be pressed. Or you also here, write please, tachycardia, because of the influence, pressure of the heart and pericardium, it is reflexogenous, you know. Any pressure of the pericardium, it is activated sympathicus. And it gives the tachycardia. Continue, please. Fourth group of the sign and symptoms. Fourth group of sign and symptoms. It is for Pancoast type of the tumors.
Shoulder, neck pain.
It is the neck and upper extremity signs. First of all, the Bernard Horner sign, which I say you before, ptos, meos, and end of tau. Ptos, meiosis, and end of tau. Ptos, meos, and end of tau. And second, it is pain projection into the neck and into the shoulder region. Very specific, guys. For Pancoast, I say you before, the Pancoast type of the tumor mainly damaged the upper lobe of the lungs. And as you remember, 1 minute, listen to me. Upper lobe of your lungs, apex of your lung, located in neck region.
Near brachial plexus.
You know about it. That is very important. That's why in the future, friends, then you will make, for example, auscultation of your patients. Don't forget to put your phonendoscope in the supraclavicular fossa. Especially if you will work in pediatrical surgery. I told it for you previously that main type of the pneumonia, it is apical pneumonias, because apex of the lung has the worst arterial supply. Remember about it. This is the reason why we will have the cervical signs, because we will have volumetric process, not inside of the thorax, but inside of the neck region. Now write please, next group, number 2, signs and symptoms of secondary metastasis or secondary lung tumors. This here, guys, it's very funny and stupid to speak about it because comparable with place of location. Comparable with place of location. For example, look please here. What do you see?
Bone.
What do you see?
Fracture.
Pathological.
Fracture.
Pathological fracture. This is the fracture which doesn't have any attention to the trauma. Your patient will say, I take the glass of the water, I feel the hard pain in the bone, we make X-ray and we see the fracture. For example, if I will look to this fracture, generally, I will not see here any metastasis. But I will see multi-fragmental fracture, which is usually, go for which age?
More after 60 days.
Why?
Because
Osteoporosis.
osteoporosis, especially estrogen.
Osteoporosis, she's right. Tumor eat the bone tissue. And in the picture, we see classical fracture in case of osteoporosis. Osteoporosis fracture, it is also pathological fracture. But of course, this is another case. This is really the bone metastasis from the lung cancer. And unfortunately, guys, just by X-ray, you cannot put the diagnosis. By the way, I want to show for you here another picture. For example, this one. Look here, please. What do you see here? You see absolutely classical sign for rheumatoid diseases. Arthritis, guys. Hypertrophical processes, hypertrophic osteoarthropathy. You can see very thick periosteo. You can see inflammational process in the phalanx. It's like, by first point of the view, then you will look to this picture, you will see it is rheumatoid arthritis. But in real case, that is the sign and symptoms which is connected with the lung cancers. Which sign and symptoms? It is sign and symptoms of hypoxia. Hypoxia, clumping, which is usually problem of the chronic heart failures. Yeah, and you can see the rheumatoidal inflammation inside of the small phalanx. Not only in upper extremity, in the lower extremity, they absolutely same. This is the, guys, 1 minute attention. This is the problem of small cell type of the cancer. Look please to me. It doesn't show the local signs. It doesn't show local signs and you lose the time because locally it is small tumor. It doesn't give any value. Even the patient will not have cough. But we will see formation of the huge amount of the distant metastatic signs and symptoms. Cracking of the mediastinum, problems connected with the bones, problem connected with the brain, problem connected with the liver. And these patients, of course, I don't say long time because they doesn't live long. But sometimes they treat it for absolutely another problem and they lose the time. Because nobody from that persons don't understand and recognize that the problem connected with the lungs. This is problematical. In case of adenocarcinoma, huge, then the tumor is seated inside of the lung, person cannot breathe normally. We'll go make X-ray and by simple plain X-ray we'll find the problem. Absolutely another picture will be here. Absolutely. I remember the patient who is 1 year treated by from bile duct inflammation, and finally then they make cholecystectomy. Only after this pathologist find the tumor inside of the gallbladder wall. After this, of course, patient is live approximately 2-3 weeks, because then you cut the tumor, it is more aggressively start to spread. Remember about it, guys. Special type of the sign and symptoms which I promised to show you. Cushing. Because acute cells can produce adrenocorticotropic form of the hormones cortisol, and they gives the classical Cushing. As I say, not only Cushing, different type of the hormones, diuretical, antidiuretical hormones, parathormone. Very interesting, guys.
Hypercalcemia.
Production of the parathormone, what it means?
Calcium.
Hypercalcemia. A high concentration of the calcium, the person will lose the consciousness, have the problem with the vascular system, vasculitis, formation of the vasculitis, bleedings from small nasal bleedings, hypercalcemia. Interesting, yeah? Acute cell tumor, which give absolutely endocrinological problem, but that is the sign of the lung tumor. Don't be confused in the future, guys. Even in the literature, I find that it can produce the estrogens for females, production of the estrogens. And it is show absolutely problems which is connected with endocrinological. For example, for the males, gynecomastia. Absolutely an understandable situation, and you see so hard will be to make diagnostical investigation and to understand that this is the lung tumor. For Pankos tumor, I tell you, yeah, mainly it is the cervical signs, projection of the pain, formation of the Claude Bernard, about all these questions. But by the way, look this so beautifully. Simple X-ray show for us the Pankos tumor. Guys, I suggest you to use these pictures which I apply in your slides. That is not for beauty. This is the pictures which has, by the way, resolution is very big. You can enlarge it how much, how you want. And it is very symptomatical. What do you see? Low pneumonization of the apex of the lung. We don't have the air. They say this is the generally atelectase. Generally it is atelectase. But this is not the simple atelectase. This is the Pankos type of tumor. By the way, very resemble for children's atelectasis, which is